The uterus is a remarkably adaptable organ, but it does not always follow the standard upside-down pear-shaped blueprint. Structural variations, often referred to as mullerian duct anomalies, develop during embryonic formation when the two mullerian ducts, which normally fuse to create the uterus, fallopian tubes, cervix, and the upper two-thirds of the vagina, do not develop, fuse, or resorb tissue in the typical way. As a result, the uterus can form in several different shapes. Some of these are considered normal anatomical variants, while others are congenital structural differences present from birth. One example is a septate uterus. This congenital condition occurs when a band of fibrous or muscular tissue divides the uterine cavity either partially or completely. In most cases, the outer shape of the uterus appears normal, but the inner cavity is separated by a septum. This septum may extend only partway down the uterus, known as a partial septum, or continue all the way to the cervix, known as a complete septum. Because this variation primarily affects the uterine cavity and not the ovaries, hormone production and ovulation usually remain normal. Many individuals experience no symptoms at all. However, a septate uterus has been associated with recurrent pregnancy loss, implantation difficulties, and abnormal fetal positioning during pregnancy. In many cases, a minimally invasive procedure known as hysteroscopic septal resection can greatly improve reproductive outcomes. Another well-known variation is the bicornuate uterus, often described as a heart-shaped uterus. This congenital anomaly develops when the mullerian ducts partially fail to fuse during embryonic development. The result is a uterus with two upper cavities, or horns, along with a visible indentation at the top portion of the uterus, known as the fundus. Although most cases involve a single cervix, the degree of separation can range from mild to more pronounced forms. Many women with a bicornuate uterus continue to have normal menstrual cycles and typical hormonal patterns. However, the altered uterine shape and reduced space within each cavity may increase the risk of miscarriage, preterm birth, and abnormal fetal positioning during pregnancy. A unicornuate uterus is a rare congenital anomaly in which only one side of the uterus fully develops, and it is typically connected to just one fallopian tube. In some individuals, a small underdeveloped structure known as a rudimentary horn may also be present on the opposite side. This horn may either communicate with the main uterine cavity or remain completely separate. Because the reproductive and urinary systems develop closely together during embryogenesis, a unicornuate uterus can sometimes be associated with kidney abnormalities on the same side of the body. Hormonal function is usually unaffected because the ovaries, not the uterus itself, regulate the menstrual cycle. If at least one healthy ovary is present, ovulation and hormone production generally continue normally. And when both ovaries are present, which is common, hormone levels are typically entirely normal. Clinically, a unicornuate uterus is significant because the smaller uterine size and altered shape may increase the risk of miscarriage, preterm birth, and abnormal fetal positioning during pregnancy. In some cases, complications such as endometriosis may also occur, particularly when a non-communicating rudimentary horn is present. Another rare congenital variation is uterus didelphys, also known as a double uterus. This condition occurs when the two mullerian ducts completely fail to fuse during embryonic development, resulting in the formation of two entirely separate uterine cavities. In some cases, there may also be a double vagina caused by a longitudinal vaginal septum. Unlike other uterine anomalies, where the separation is only partial, uterus didelphys involves a complete duplication of the uterine structures. Although the condition may sound dramatic, many women with uterus didelphys experience normal menstrual cycles and are able to have successful pregnancies. However, depending on the exact anatomy, there may still be a slightly increased risk of miscarriage, preterm birth, or breech presentation during pregnancy. Even though there are two uterine cavities, the ovaries still control the menstrual cycle. Women with uterus didelphys usually continue to ovulate normally and maintain typical estrogen and progesterone patterns. In some cases, menstrual bleeding may appear heavier if both uterine cavities shed their lining at the same time. An arcuate uterus is considered a mild anatomical variation in which there is a small, smooth indentation at the top portion, or fundus, of the uterine cavity. Unlike a septate or bicornuate uterus, the outer contour of the uterus remains normal. and the indentation within the cavity is shallow and broad, rather than dividing the uterine space. Most specialists regard an arcuate uterus as a normal anatomical variant, rather than a true congenital malformation, and in most cases, it does not negatively affect fertility or pregnancy outcomes. Women with an arcuate uterus typically have completely normal reproductive function and may never realize they have this variation unless it is discovered incidentally during imaging for another reason. Perhaps the most fascinating aspect of these uterine variations is how many people have them without ever knowing. Current estimates suggest that approximately 5% of women have some form of uterine anomaly. Many go through life, have healthy pregnancies, and reach menopause without experiencing a single symptom. In fact, these anomalies are often discovered accidentally during an ultrasound performed for an unrelated reason, or during evaluation for issues such as breech presentation during pregnancy. Thank you for watching.